Hello, and welcome to this session on managing service disruptions that have occurred because of the COVID-19 crisis in hepatitis C services. My name is Cary James. I'm the Chief Executive of the World Hepatitis Alliance, and we're a network of over 300 community-based organizations and organizations led by people living with hepatitis, really focused on its elimination. And over 100 of our members are currently working in fast-track cities. And we joined as a partner for the fast-track cities initiative this time next year to really help accelerate the hepatitis-related work that's part of the program. Obviously, since then, the COVID-19 crisis has interrupted all of the work that we do. And we know by the surveys from our members that just about everyone was affected. And screening services and care and access to treatment were all disrupted on different levels around the world. So I'm really pleased to be joined today by Rachel Halford, who's the Chief Executive of the Hep C Trust, which is based here in London, one of the fast-track cities. And we're going to talk about how they've really grown and adapted to adjust to the current COVID-19 crisis. So welcome, Rachel. Thank you for joining us.
Thank you. Thank you very much for inviting me. It's lovely to be here.
Great. So maybe you could just tell us a little bit more about the Hep C Trust and its work.
Okay, so the Hepatitis C Trust is a patient organisation. We were set up about 15 years ago now, and we were set up primarily because there were no services for hepatitis C. Lots of organisations providing HIV advice, but nothing for Hep C. Roll on to today, and we are very much so we started as an advocating and lobbying organisation, and today we are also a service provider. The core of the work that we do is we deliver peer services across England, Wales and Scotland. And we deliver peer-to-peer work, raising awareness of hepatitis C, testing, identifying people, and then supporting them into accessing treatment. That's a really quick synopsis, and takes out a lot of the work in between. But I think that yeah, it tells you a bit more about who we are in terms of we deliver a lot of operations on the ground.
Big cities in the UK, right? Like not only London, but also Manchester and other places, right?
Yeah, so we work across England. We work in Brighton, we work in Liverpool, Bristol, London. Manchester, we do some work, but I mean, for anybody who knows anything about Manchester, Manchester has a little bit more autonomy than other cities in the UK. And they do an awful lot of the work on their own. We do more support work there. In terms of anything outside of England, which would be Scotland and Aberdeen and Glasgow, we run small projects, but they have a different health system, as does Wales. So our work in Wales is limited and our work in Scotland is limited, but we do have a presence and we do more lobbying and political work in those devolved nations rather than what we do in England, which is more operational.
All right, okay. And in London, I know that there's a really good system of joined up working that occurs in London around the elimination. Could you tell us a bit about that?
Yeah, I mean, I think in terms of hepatitis C, London has always been at the forefront and has been working for a long time on hepatitis C. I think that we've been very lucky in more recent years to have the GLA, so the Greater London Authority, and the Mayor's Office on our side as well. So London has the Mayor's Office, which a little bit like Manchester, whereby the mayor has, he runs all of London essentially, and he has his own initiatives and he has his own investments. We've worked for a long time very closely with the GLA. We also work very closely with a group called the London Joint Working Group, and that's a group that was formed, I couldn't tell you how long ago it was formed, I'm afraid, but I actually sit on their board now, and they are, I suppose, I mean, the best way is a bit of an umbrella organisation that work with drug services and specifically around hepatitis C. So they run a lot of pilots, a lot of initiatives. So for example, more recently when we've worked with the Greater London Authority and the Mayor's Office, the London Joint Working Group have led that. And what that does is it gives us a way of everybody coming together. It's like it's an umbrella which brings all the different providers, whether that's health or providers like ourselves, patient organisations or drug services. It brings us together. They put on incredible conferences, and what they do is they keep they raise the awareness, you know, and they keep the news on the agenda in terms of through the conference, anything that's happening and changing in terms of when the new treatments came in. We always have had a forum in London to kind of spread the message and spread the news.
Okay, so I mean, thinking back now to March, really, when the stay-at-home orders really started in the UK and in London, I mean, what was the impact of that to the trust at those early days?
I think, like everybody else, you know, there's no doubt that it was exceptional and is still exceptional times that none of us had experienced before. For us as an organisation, we have a base in London, but predominantly, you know, out of our 60 peer support leads, people we employ, we have volunteers, but people we employ as well, they work from home anyway. So for us, it was really about getting the information out there to our staff team, making sure they had the right equipment to work at home, and then shutting the London office down. I think for, one of our biggest concerns were, as we had spent the previous year building up our workforce, you know, tying in with, you know, doing a lot of recruitment, which had come under the elimination deal that the UK or England had done with the pharmaceutical industry. So we'd spent a year building up our workforce, and then wallop, we just had to shut it down. I think one of the things that I'm really keen about talking about or mentioning, you know, kind of when I talk about it is that there was lots of information for big organisations in terms of what do you do, these are the processes, but there was very little for charities or small patient organisations like ourselves. So we had to, in terms of looking after our staff, make sure everyone could access Zoom. We had to set in process, you know, what do you do in shutdown? What do you do in partial opening? What do you do when you open up fully? I mean, it's a completely new landscape, which none of us had known before. But really, you know, as a patient organisation and with the patient in the centre, our biggest concern was the patients that we were supporting at the time and our volunteers. You know, as we shut down, we had over 2,000 patients that we were providing one-to-one support to. And there was a really quick assessment that we had to do in terms of how can we maintain contact? How can we carry on working throughout this period when we have all these restrictions? Initially, a lot of our work was on the telephone. We made sure that patients or peers or volunteers that didn't have telephones, we got them telephones. Zoom has become a saviour, as it has done for most people. We managed to set up a whole schedule of training for not only for our staff but also for our volunteers to access, so that there was some kind of contact. We also delivered medication, so where people who were on treatment couldn't get to hospitals or were too scared to go to hospitals, we had peers working out in the community, going to hospitals, picking up medication, delivering them to people who were still on treatment. I mean, we did a kind of dirty, kind of quick assessment of all the outcomes. I mean, overall, we had over 4,000 interventions that we completed from the shutdown period through till the end of July, which is an awful lot of interventions. People were still starting treatment. There was no testing. But things like telemedicines and just peers taking the lead really came to the forefront. I suppose the one caveat to put in there is that we had to, of course, write new risk assessments. We had to make sure everyone had PPE, which doesn't come cheap. And then, you know, as I'm sure everyone listening will remember, when it all happened, you couldn't buy PPE. You know, you couldn't find it because everybody had brought it. So it's been huge. It's been a huge learning. But within that, you know, there's, yeah, a lot of growth, and we've learned to work in different ways. And for all the negatives, there are positives too.
Absolutely. I was really struck when we talked about this earlier about, you know, buying mobile phones for clients because so you could contact them or topping up their phones. Maybe you could talk about some of the, you know, the really new things that happened like that, because I assume that didn't happen very often previously.
Not in the way in which it did when we had shutdown. I have to say that when we started, you know, we're a charity, we're a small organisation, we don't have masses of money, you know. So originally in the beginning, when shutdown first happened, we were going on, all our staff were going on Facebook begging people if they had an old phone. We had lots donated. And then as time kind of went on, you know, we're not out, we weren't, you know, we had a little bit of cash whereby we could then provide them with phones so that they could have contact. And I think that you cannot, you know, and today it's even, you know, more prevalent, but you cannot underestimate the impact on mental health that COVID has had, you know, for people who, you know, people who are using, you know, they can't go out, they can't do what they do to get their money. They can't necessarily go out and get a clean syringes. They can't necessarily get to the drug services. Everything's shut down. So for those most vulnerable of groups, having some kind of contact, having a food parcel, we delivered loads of food parcels. You know, people just didn't have, because they couldn't go out and graft, and that's a reality, you know, that people have to graft, whether they're stealing, whether they're begging to get their money, and they couldn't do that. They had no food. So it was really about going right back to basics, getting on the ground, which is what we do anyway, and just making sure people were supported. And I guess, you know, we'll come on to it in a minute, I'm sure, but the homeless people, was a huge piece of work was done around that at the same time. I think that the other thing we did was, and I know I talked about just now, was Zoom, you know, utilising that social media platform of Zoom so that all our peers and volunteers could access training. We have a whole day donated to them. We did weekly, we had daily check-ins, we even did meditations. You know, and peers and volunteers were all welcome and did join everything that we did. Yeah, I mean, I guess that in a sense, I mean, I'm actually really proud of what we were able to provide, you know, within that time. I think it's a strength of the voluntary or charitable organisations that when we're a grassroots, or what was a grassroots organisation, we've coped with very little, and we've coped under restricted environments. So, yeah. We are quick to turn it around, I guess, or make the most of what we've got at the time.
Absolutely. And I think the model that the Hep C Trust uses, the kind of peer-to-peer model, is so important when you have to make those kind of quick decisions and that realignment of services, right?
Yeah, completely. And I mean, that in terms of, you know, homeless people, can I talk about that?
Yeah, please. Yeah, definitely.
I think that was one of the biggest things for us. So, you know, a lot of, you know, when we were out there on the streets and our peers are out there connecting with some of the hardest, they're not hard to reach because we know where they are, but they're very hard to engage. And that generally is the homeless population, the rough sleepers. You know, and what COVID did, which is, you know, the irony of you can very quickly put all these people into hostels and hotels, does make you question, why couldn't you do it before? But actually, I'm not going to go there now. So we did, it was done. And I'm quite surprised I'm sitting here today and actually the funding's been extended. So people, you know, homeless people are still in hotels and hostels in the UK, which is fantastic. Great. But what we managed to do was to I want to say take advantage, but I mean it in the best possible way, of people being in hotels, of being in one set place. You know, so it wasn't just a matter of let's put it, so for London, the example, London is a great example. It wasn't a matter of the greater local authority or local authorities saying, let's put them in hotels. It's like, what can we wrap around them at the same time? So what services can we provide? We want a substance misuse service. There were a group of clinicians and outreach services that came together with the trust. So we worked with them so that we could go around to each of the hostels and do what we call hits. You know, we do them in prisons, and they're whole hostels or whole hotel testing. So what happens is at the beginning of the day, you've got a doctor, you've got nurses, you've got peers. The peers go and engage and hopefully encourage the people who are in their rooms, bring them down, they get a test, and they're tested for BBVs, HIV, hepatitis B and hepatitis C. It's an amazing window of opportunity to address people's health, you know, amongst other things, their health concerns and their health issues, because like I say, they're not hard to reach, they're just particularly hard to engage. And it's an incredible opportunity. And our health systems aren't set up for people who are on the streets. This has flipped it all around, and it's been incredible to be involved in, something that's flipped it around. So this started in London. And then I think now, I mean, in the first 6 weeks, we attended 46 or our peer workers attended 46 different testing events. Now today, I can't even give you a number, but the initiative just spread across the country and across England, definitely. Homeless people that have been put into hotels and hostels have accessed all sorts of other support, including testing for hepatitis C, HIV, and hepatitis B. And that's phenomenal. It's a no-brainer. It's a really great outcome from this, is that such a marginalised group has actually got the support that it needs during this really tricky time.
That's incredible. So you've seen more homeless people being diagnosed with hepatitis C under this new structure?
Yeah, I mean, there's not at the minute. I mean, I can't sit here and give you specific numbers. In the initial days, we found 11 out of something like 400, which is quite a small percentage. But I think that one of the things that came to light very quickly was, you know, whilst we have a hotel or a hostel, a lot of people were going out during the day to try and graft, even irrespective of the fact that it was very difficult to graft. So we've had to keep going back. The numbers have risen considerably, and you know, we will publish them, and we will put them on our website so people can see. And like I say, this is a joint. It's been a joint program of work as well. So there'll be people like UCHL, the Find and Treat Ban, across London, and then across the rest of the country. But the numbers of people being tested, actually, considering we were in shutdown, were really quite high. We found a couple of people with HIV in London. We found a hepatitis B in London. And this was just within the first 6 weeks. So these are people who would not have been found had it not been for them being shut down into these hotels or hostels.
Yeah, no, it's incredible work. You mentioned a little bit about people who use drugs and the services for that, but I'm sure people will be interested what your service looks like now in these new conditions for that group, since it's such a big, important community for you guys.
I think it's really difficult to answer that in terms of what's happening for people who use drugs. I think that what we hear is that drug services are coming back to normal, and I think that there are changes, but I think like us, they will change the way they deliver their services, or there will be more people perhaps continuing to work from home. I think there were a lot of lessons learned during this. For example, people who are using drugs or people who are on OST, they actually can manage a longer prescription than necessarily thought in the first place. You know, they manage quite well, you know, whereas they had to come in and do a check-in in an office and have a test. I think we're going to see some changes. So how do I say this diplomatically? The official line is that services are on their way back to normal. On the ground, I don't think that's quite happening at the moment. What we hear on the ground and what we see on the ground is it's not quite there yet, possibly because newer models are going to come into play. I know that some of the drug services that are looking at perhaps using different models of testing, it might be. So testing really is our biggest concern. So most of our testing in England and across the UK happens through drug services. You know, and if the drug services are running in a different capacity or a different way and they're not seeing so many people, we then really have to seriously look at how we're going to keep the testing numbers up. One of the initiatives we've heard from one of the drug services is do postal tests. And I think that they're on it as well. I've met with lots of different providers, you know, and they are well aware of needing to be back where they were. But it really is, like all of us, you know, do we need to work in the way in which we did, or is there something we can learn from the lockdown and how we are now? You know, I know a lot of my staff will be working from home that used to come to an office, you know, so I'm not in a position to say, but I guess it's more about watch this space, you know, because drug services did stay open. There were some services that ran a skeleton service for people who wanted to go onto OST during COVID, you know, and I think there were a lot of scary things that happened. I was in a meeting speaking to somebody from New York, for example, the other day. You know, they are seriously concerned. There were no harm reduction services. They think they've got a massive spike in Hep C because there were no harm reduction services. there was a lack of harm reduction. So when I say that, I mean needle exchange particularly, or the people who ran out of, couldn't buy street drugs, so they were actually, or couldn't get their OST, so they were just sharing and using anything that they could find. So consequently, there could too be here a spike because of the period of lack of needle exchanges or harm reduction services. I think it's too early. More will be revealed. Yeah, and I'm not an expert. I'm not an expert by any means. We are working with drug services, but we are, it's slowly. Is that too much?
Absolutely, thank you. No, that's terrific. No, that's terrific. Thank you. And you mentioned before about how you're using, kind of Zoom and other platforms in order to do some of the peer support that you guys normally offer. Could you talk a little bit more about that and how that works in practice?
Yeah, so I mean, the whole thing about a peer is, I mean, and there's nothing like face-to-face support. Absolutely, it's very difficult to create a relationship with somebody over Zoom. I guess we're all getting better by default. We have to get better. So what we did was that it's about our training that we've done. We've utilized Zoom so that we train peers. So when we bring in a volunteer, so we have paid peers and they're people who work for us, and then we have volunteer peers. And what we do is we take them through lots and lots of training and support. What we managed to do was to do all of this over Zoom. So we would make sure we would either buy or make sure someone had access to a Zoom platform. We opened up our office space here so volunteers could come in and use computers here. And of course, I have to say, it's all very safe because of COVID. And that's how they've accessed their training. In terms of, I suppose, sitting alongside that, which really is, I think, where you're going with this, is there's been a great increase in telemeds. I was talking to a clinician from the Newcastle area, and during the COVID lockdown, he managed to treat every positive hepatitis C within a prison. And that was utilizing telemeds. And these things, telemed has been around for years, but it's never really been fully utilized. It's just kind of like dipping in and out. I think we're going to see a massive difference. I've talked to clinicians who now, many of them have said that they will be doing Zoom meetings, very few face-to-face meetings. This really will change the way in which we all work. In saying that, I think for us, when we're talking about finding the hardest to engage and the people that there's still going to be a lot of face-to-face work, but where we have to, if we have to, we can use Zoom. I think that's what we learned. That's the biggest thing, and the greatest thing we learned was that we can still function even if we can't get out there.
Yeah, absolutely. I think it's really accelerated things, exponentially, right? We took a giant step forward. I think before, lots of people were taking baby steps in this direction. And the COVID crisis has really made us kind of take that leap, I think.
Yeah, and I think one of the best things that came out, particularly in London, was the partnership working. When we talk about, and you were asking about what happened in London, the homeless people going into the hotels and the hostels and the unity, it was so quick, to do this piece of partnership working. There were clinicians, like I said, there were clinicians and nurses, and then you've got the outreach vans coming, and then we've got the London Joint Working Group were involved in helping to set it all up, and we've got a template, everyone's filling in where they're going. It was the most fantastic piece of partnership working. And actually, the only way anyone gets through a crisis is by working in partnership, working together. Mm. And this really brought it to the forefront. What one person couldn't do, another person could do. We could go in and support, and by each playing our roles, it sound a bit evangelical. I'm not by any means, but we crave for that whole kind of, particularly as a patient organisation, because we're always like the poor relative. But during this, I don't know, something shifted, because everyone had to be seen on an equal, because no one had any more kudos than anybody else. We were all in the same situation, and we put together this incredible partnership model.
Yeah. No, it's incredible. And that's the thing that never stops to amaze me about community organizations. If that door shuts, you know what I mean? They kick open a window, do you know what I mean? It's not, they're not going to have to go through some kind of big review like a health system would kind of do. You just find the way to serve the communities that you care about, and you do what it takes, right?
Absolutely, and you know that's why we are where we are, and I guess in a way, you know, we can say what other people can't say because we don't have exactly like you say the boundaries. We can lobby. We don't lose focus because this is our main objective, and this is, you know, we're here for the elimination of Hep C. We as an organisation will close down. We're not going to dive to any other liver disease or carry on. Our main mission is to close when Hep C is eliminated, you know, and whether that's 2025 in the UK or whether it's slightly later than that, we will be closed. We're not going to be anything else. So, yeah, we're able to keep our focus because there is nothing else to focus on outside of that. I guess the well-being of the people that work for us, you know, and the volunteers, and make sure that they get the training and the support that they want to go into employment, and that our staff, when they leave here, they can leave and, you know, get a better job, I guess. You know, so that's our focus alongside, that's it, which enables us then to really lobby, shout out when there's something going on that's not right. Yeah, and I guess just really, I think it's important to say that, you know, we're really privileged here in England at the moment. We have an elimination deal, and what comes with an elimination deal, irrespective of the lockdown of COVID, is there comes a commitment, and you get action from that commitment because everyone's on this deadline of 2025, and there's been an investment. You know, there's an investment in the pharmaceutical industry, NHS England. And so we're actually in a fortunate position because we can keep moving forward. You know, we have to shut down with something like COVID or our services are minimum. But actually what we see is that everything's starting to open up and pick up. There is this massive impetus and commitment to get up and running as quick as possible. And I think that I know from when I talk to colleagues and friends across Europe or across the globe, we're actually in a very lucky position.
Absolutely, absolutely. So, I mean, kind of looking forward, I mean, we're sort of 7 months in since the first lockdown. Things have loosened up a little bit, but we're by no means, you know, we're by no means finished. You know, we're still in the midst of this. So what challenges do you guys foresee, you know, operating in the, it's not a new normal, but in the current situation and kind of looking to the future?
I think the biggest thing would be the unknown. You know, I spoke to someone this morning and are we going to have a shutdown again? I think that, like I said just now, you know, our biggest concern is testing, because if we can't test people, we can't find people. So we really need to, you know, kind of get out there and find a way of testing people. There are a lot of new initiatives coming on, but it's about thinking outside the box. You know, there might be some stuff in some pharmacies, postal testing. I think it's continuing to work outside the box and be open-minded. I don't think there is an answer at the moment. Working in this environment means that, you know, for someone who's running an organization, you know, it's continually, you know, having to buy PPE equipment, make sure we've got the right risk assessments in place. And it's important to say that, because I think that everyone thinks, oh, it's just about being out there. If we can't be out there if the core of us isn't running right, you know, and for us to be able to run right, we have to have all the policies and procedures and operations in place to enable us to do that. So I guess the thing is about watching. It's probably trickier for us internally in terms of managing the organisation than it is for our workers out on the ground, because they are so flexible. They are out there testing people. They are out there beginning to do more work again. We've capitalised and gone to hospitals and got their backlog of lists. So we're working through their list. We're contacting people who were tested a while ago and haven't accessed treatment. In terms of, you know, testing events, we'll have to wait and see. You know, prisons is really difficult. You know, when COVID happened, all our prisons across the country went down into, they call it gold command mode, which means complete shutdown. You know, there are prisons which are opening up, but, you know, the female estate, for example, isn't open yet. So that limits the amount of work that we can do in prisons. We have on our schedule to be doing whole prison testing in specific prisons. We're it's dependent on where COVID's at as to whether we can go forward with that. So I guess it's, like we said just now, we will just have to adjust. If there's a shutdown again, or if areas are shut down, we have to adjust. To an extent, we're already doing that. We have a worker in Leicester. He's done an amazing piece of work, you know, constantly, whether it's people out in the streets or picking people up who we know are positive as they leave prison, and then Leicester went into shutdown. So he's just had to revise all his work again, take it back in, go back to, you know, on the phone, video calls. For the people in prison, we're writing to them, we're sending them newsletters. We just have to be really flexible in what we're delivering, because there's no set, for none of us, we don't know.
Mm-hmm. Yeah.
We really don't know. I don't
Absolutely.
have an answer. We just take one foot in front of the other and, you know, take our learning with us.
Absolutely. And what do you think? I mean, obviously this has been a terrible time for so many reasons, but it's also been a time of kind of change, innovation. So what do you think has been like a positive development that's happened during this time that you think is going to improve your services for the future?
Positives, I hate to come back to it, but it would be how we communicate. Zoom, we've become far more efficient in how we communicate. So we've actually become closer as an organisation. There's a greater unity within the organisation, because as a national organisation, people are spread out hundreds of miles apart. Because we've had to be on Zoom, there's great relationships going. We as an organisation had to be creative in terms of the training that we gave our staff. So we've become better as a organisation at looking after its staff. I think probably we look after our patients and the people we're supporting into treatment really well, but we had to do it in a different way, which then meant that I think we probably do that slightly better, you know, because, you know, yeah, I think because you have to work differently. Telemedicine has been incredible, and I do hope that they continue. We've learnt, one of the best learnings is that we've learnt that peers can do more than anybody thought they could do. You know, that you don't have to, you know, there's a lot of problems in this country in terms of who can pick meds up from a pharmacy. Actually, that law, that can be, you can go around that during COVID, so you can go around it outside of COVID. Why does somebody, they don't have to go, we can pick the medication up, the peer can do it. You know, the peer can pick the medication up, take it out there. There's a greater desire now for outreach models. You know, so I think the learnings are that the whole Hep C doesn't have to be completely held by a hospital. There are lots of other creative ways that it can be done, and that the peers can take on a greater role within that.
Yeah.
That would be a really good outcome for us.
Absolutely. That would be amazing, you know, for that to extend into, you know, in different settings and around the world, and, you know, all different things. So maybe just, I mean, we're almost out of time. We could talk about this all day, but I think just maybe just one last thing, kind of, you know, thinking about everything. I mean, there will be plenty of people out there in cities around the world whose Hep C programs have been interrupted, and, you know, they're having a hard time getting them back going again. So, well, I mean, what advice would you give to help get HCV elimination programs back on its feet in cities, you know, around the world?
I think there's two things. It's not, I don't think it's not, I wish I had a magic word that would go, do this, this and this, and then here we would be and we'd all eliminate. But we all know that, you know, if you don't have an elimination deal, or if you do not have commitment from your government towards an elimination deal, and when I say commitment, I mean commitment with action, preferably with money as well, but you need that. If you don't have that, then I think that you really struggle. We are really lucky because we have this commitment. However, COVID is the main thing. COVID is the main man. You know, it takes over everything. I think that my advice would be one foot in front of the other and find another. If you can't do it the way you were doing, find another way to do it, but keep persevering. You know, this isn't lost. Everything is going to come back to a new normal. And we within it, you know, we have to be creative and we have to find a new normal within this, you know, so we can't just kind of put our hands up and go, oh, well, it doesn't work anymore because I can't work the way I used to. We have to find another way of working. And actually, I bet people listening will go, well, actually, I did. I think we're all really creative. So people were and have already done it. Just carry on doing it. And if you haven't got your government or your local authority or whatever it is in your country on side, get them on side, lobby, use the time to lobby them. Because actually, there is no cure for COVID. There is no vaccine for COVID at the moment, but there is a cure for hepatitis C. And what that means is there's a cost benefit to your government's purse, let alone anything to do with the individual. You know, and I would always talk about the individual, but if you've got to convince a government or a local authority or a city authority, tell them how much money it saves them and lobby them.
Absolutely. Well, that's great advice. And unfortunately, we're out of time, but I'd just like to say huge thanks to you, Int'l, for taking time out to speak to us today. And to everyone who's tuned into this session, thank you very much. And hopefully we'll see you again in person soon. Bye-bye.